Welcome to the PMHNP podcast, the definitive podcast for those passionate about mental health throughout every stage of life. Whether you're an aspiring professional, a seasoned expert, or someone simply keen to understand the intricate world of psychiatric care, you're in the right place. I'm Dr. John Rossi, a certified PMHNP, nurse educator, and lead content creator and instructor at Clarity Education Systems and www.PMHNPtesting.com. All right, welcome back. I'm excited to be able to talk to you today about something that you are probably already seeing in clinic. If you're still in your clinicals at your program, it's definitely shown in various levels and stages in the clinical setting, both inpatient, outpatient, intensive outpatient, PHP, virtual IOP, it's everywhere. And that's alcohol use disorder. And so today we're specifically going to talk about the disorder itself, kind of what the classifications are and what the DSM-5 puts out. Screening and treatment options. That's what we're going to focus on in today's podcast. So first things first, what is alcohol? Alcohol, or specifically ethanol or ethyl alcohol, is a psychoactive substance found in beverages such as beer, wine, spirits. It's produced by the fermentation of sugars by yeast. So alcohol acts as a central nervous system depressant and is one of the most commonly used recreational substances in the world. So why is alcohol abused? So alcohol abuse occurs due to the combination of genetic, psychological, social, and environmental factors that can influence an individual's drinking behaviors. So let's talk about some of the reasons why alcohol abuse might occur. So one, social factors. Drinking is often culturally and socially encouraged, and it can be associated with social activities, celebrations, and rituals. Then we have stress relief. So many individuals use alcohol to cope with stress, anxiety, or depression, though it often exacerbates these issues over time. Pleasurable effects, right? Alcohol consumption releases dopamine in the brain. This is going to create a feeling of pleasure or a high that can lead to repeated use and abuse as one seeks to recreate and to refine these feelings that they're having. And then finally, it's addiction. So alcohol can be physically and psychologically addictive. Regular use can lead to that tolerance and dependence. So where more alcohol is required to achieve that same effect. And alcohol withdrawal symptoms occur if that drinking is stopped or reduced. Now, alcohol affects multiple parts of the brain and interacts with various neurotransmitters. And this is going to contribute to its wide-ranging effects on mood, behavior, and physical control. So we have to understand the specific areas of the brain and the neurotransmitters involved in order to help us understand both the acute effects of alcohol consumption and that long-term consequence of alcoholism. So let's talk about the brain areas affected by alcohol. First, we have the cerebral cortex. Alcohol depresses the behavioral inhibitory centers in the cerebral cortex. That leads to decreased inhibition, which can cause an individual to become more talkative, more self-confident, and less socially inhibited. It also slows down the processing of information from the senses, leading to that impaired judgment. Next up is the limbic system. So this area, which includes structures such as the amygdala and the hippocampus, really regulates emotion and memory. Alcohol's impact on the limbic system contributes to mood swings and memory impairments. Now, it can also affect risk-taking or decision-making behaviors due to its effects on reward pathways. Third, we have the cerebellum. So alcohol affects the cerebellum, which is responsible for that motor control, leading to incoordination and an unsteady gait. The hypothalamus and the pituitary gland. So alcohol consumption it has that ability to influence these structures, affecting hormonal release. And this can lead to sexual dysfunction, and it can also interfere with reproductive functions of the body. Finally, the medulla. So this part of the brainstem controls automatic functions such as temperature regulation or breathing and consciousness. High levels of alcohol can depress these functions. This is going to potentially lead to life-threatening consequences like respiratory arrest or even a coma. Moving on to the neurotransmitters that are involved with alcoholism, we first have the GABA. Okay, so alcohol enhances the effect of GABA. And remember, this is an inhibitory neurotransmitter. Increased GABA activity leads to sedative effects commonly associated with alcohol consumption. This also contributes to the depressant effect of alcohol on the nervous system. So glutamate, alcohol inhibits glutamate, which is an excitatory neurotransmitter. Inhibition of glutamate prevents the body from becoming overly excited. This is going to further contribute to that sedative effect of alcohol. Third is dopamine. Now, alcohol increases dopamine levels in the brain's reward center, which reinforces drinking behavior by creating feelings of pleasure and satisfaction. This dopamine release is a key player in the development of addiction in the brain, and it associates alcohol with that need. And then we have that use as a positive reinforcement. Fourth is serotonin. So this neurotransmitter affects mood, right? It also is influenced by alcohol. Changes in serotonin levels can explain why alcohol sometimes seems to alleviate anxiety in the short term, yet it leads to depression in long-term use. And then finally, we have endorphins. So alcohol stimulates the release of endorphins, which are natural opioids that enhance feelings of well-being and can decrease things like pain. So like dopamine, the endorphin release can contribute to those addictive properties of alcohol due to its pleasurable effects. So differences in alcohol intoxication are going to exist between men and women. Just physiologically, there is a difference between body types. So men and women metabolize alcohol differently due to those differences in body composition and their biochemistry, and this is going to lead to different effects in alcohol intoxication. So first up is body composition. Women, they generally have a higher body fat percentage and a lower percentage of water than men. So since alcohol is water soluble, but not fat soluble, it remains more concentrated in women's bodies, leading to higher blood alcohol concentration, or BAC. So this is going to be different than men of the same weight who drink the same amount of alcohol. Second is their enzymatic activity. So women have lower levels of alcohol dehydrogenase, and that's the enzyme that metabolizes alcohol in the stomach. So this is going to result in greater proportion of ingested alcohol reaching the bloodstream. And then third is hormonal factors. So hormonal differences, especially variations during the menstrual cycle, can affect alcohol metabolism, potentially making women more sensitive to alcohol's effects at different times. So due to these differences, women are more susceptible to alcohol-related damage at lower levels of consumption and over shorter periods of time and use when we compare it to the male counterpart. Now, what is the DSM-5 categorization for drinking disorders? It's very clear, and we've got some nice, basically, check boxes that we can utilize when we're trying to diagnose this DSM-5 categorization. So the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, or the DSM-5, is going to categorize alcohol-related disorders under the substance-related and addictive disorders category, or chapter within that book, if you will. So the primary condition related to alcohol in the DSM-5 is alcohol use disorder, or AUD, which integrates the DSM-4 categories of alcohol abuse and alcohol dependence into that single disorder measured on a continuum from mild to severe. Now, alcohol use disorder is diagnosed based on an individual meeting certain diagnostic criteria from a set of 11 symptoms, and we're going to talk about those 11 symptoms right now. So this is straight out of the DSM-5 as far as the criteria that need to be met by the individual or the patient in order to be diagnosed with some type of level on that continuum or that spectrum of alcohol use. So first is drinking more for a longer period than intended, right? So more and more alcohol consumption for more time. So if I wanted to go out and drink, with everybody that I'm socializing with, but that continues to go beyond that socialized period or time frame that I'm wanting to actually engage in alcohol use, that's when we can check off that box. Next is persistent desire or unsuccessful attempts to cut down or control the alcohol use. Third is spending a lot of time obtaining, using, or recovering from the alcohol. Fourth is cravings or a strong desire to use the alcohol. Fifth, recurrent alcohol use resulting in failure to fulfill major role obligations at work, school, and at home. Sixth, continued alcohol use despite having persistent or recurrent social or interpersonal problems caused by the exacerbation of the effects of alcohol in the body and the mind. 7, important social, occupational, or recreational activities are given up. They forget about them, or they don't want to engage in it, or they reduce their involvement because of the alcohol use. Number 8, recurrent alcohol use in situations in which it is physically hazardous. Number 9, alcohol use continued despite knowledge of having a persistent or recurrent physical or psychological problem likely caused by the alcohol use or exacerbated by it. Number 10 is tolerance. So as defined by either a need for markedly increased amounts to achieve that intoxication or the desired effect that they're looking for, or markedly diminished effect with continued use over that same amount. Number 11 is withdrawal. So manifesting either as characteristic withdrawal symptoms or alcohol or closer related substances when taken to relieve or avoid those withdrawal symptoms. So the severity of alcohol use is determined by the number of symptoms present. Mild is going to be 2 to 3 symptoms, moderate 4 to 5, and severe is 6 or more. This comprehensive approach allows clinicians to tailor the treatment and the intervention strategies that they plan on using based on the severity of the disorder. Generally speaking, there has to be a maladaptive pattern of substance use that is leading to clinically significant impairment or distress, manifested by 2 or more of the symptoms that we talked about in the same time frame of a 12-month period. So alcohol is often taken in larger amounts or over a longer period than was intended. And that's kind of like your general view that you're looking at when you're starting to approach the AUD or alcohol use disorder criteria or diagnosis when meeting with these patients or the individual. All right, so now let's roll into what this means for you as a clinician. How do you observe this? How do we screen for this and figure out what the level is and how much use has been implemented by the patient in order to get to the level of severity as outlined in the DSM-5? So alcohol use screening tests are going to be vital and crucial for detecting alcohol use disorder, which encompasses that wide range of conditions that we just talked about: excessive alcohol intake, disruption of personal ability and function, and this is going to disrupt their daily life. So these tests typically consist of structured questionnaires designed specifically to assess patterns of alcohol consumption and identify symptoms indicative of that problematic drinking. AUD is categorized into that mild, moderate, and severe degrees, with that severity based on the diagnostic criteria met. So what do we use in order to fit into those diagnostic criteria in those different levels? Well, we've got some great tools, and these are definitely going to show up on your certification exam, and you will be utilizing these in your clinical practice if you're already certified. So let's talk about each one of these specifically that we use when screening for alcohol use disorder. So just going to introduce each one of them here real quick. We're also going to talk about the CEWA later on, but these 3 tests are really our go-tos when we're trying to figure out screening capabilities for AUD. So first is the Alcohol Use Disorders Identification Test, or the Audit. So this was developed by the World Health Organization, and the Audit is one of the most researched and widely used screening tools. It's going to consist of 10 questions. There are variations out there, and these help identify individuals at a risk of excessive drinking. So studies have consistently validated its effectiveness across diverse populations and diverse settings. So that's the Audit. Then we have the CAGE questionnaire, the CAGE questionnaire. So this tool uses 4 questions to quickly assess potential problems of alcohol. It's known for its simplicity, and it's been widely used in clinical settings. It's even been adapted to not only encompass alcoholism or alcohol consumption, but for just drug use in general. But it may be less sensitive in detecting mild forms of AUD as compared to the Audit. Third, we have the Michigan Alcohol Screening Test, or the MAST. So the MAST is an older but very thorough screening tool that includes questions designed to assess the lifetime consequences and the behaviors that are associated with drinking and drinking patterns. So research supports the use of these tools in both primary care settings and mental health settings so that we can facilitate that early detection and intervention for AUD. Implementing regular screening practices can lead to earlier treatment, potentially mitigating those adverse effects of AUD on relationships, on work, and on general health. So studies have shown that brief interventions following positive screenings can significantly reduce alcohol consumption and improve outcomes. So we're going to utilize these screening tools with motivational interviewing, for example, to really help improve those overall outcomes that you and the patient have set and those goals that you have set at the initiation of treatment. So the effectiveness of these screenings and the subsequent interventions underscores the importance of integrating substance use assessments into routine healthcare practices. So this really has to be done on an interdisciplinary approach. So you, as the PMHNP, need to work closely with the primary care provider, especially in patients that are at high risk or already have a history of alcohol misuse and abuse. As health systems increasingly adopt these integrated care models, that role of alcohol screening as part of a comprehensive patient assessment is going to expand. And this is going to emphasize that need for ongoing training for you as a PMHNP, as well as other healthcare professionals, in order to support administering these tools and, most importantly, being able to interpret their results, because interpretation is key. If you can interpret what these things mean, what these screening results mean, then we can utilize appropriate mechanisms or interventions, such as, specific medications that can help with symptoms or withdrawal, as well as psychotherapy that is going to be essential for them to start to apply these coping skills and mechanisms within their life so that they can overcome these habits and these desires without having to be fully medicated. So the alcohol use disorder identification test. Let's dive deeper into each one of these now. We're gonna talk about them specifically, the structure and the content, and then what we do whenever we get certain results from these screening tests. So again, the audit. Highly effective, widely implemented. It's going to be used to identify alcohol use disorders. Developed by the WHO, or the World Health Organization, really within the early 1980s. So it's been around for quite a while now. So the audit, it's used globally, all right? So many countries, everybody's very familiar with the audit. And it's also utilized in various healthcare settings. So primary goal is to detect early signs of hazardous and harmful drinking and to help in brief assessment and intervention, and potentially to identify who needs to be hospitalized and to get them that hospitalization quickly. So what is the structure and content? The audit consists of 10 questions, each designed to assess different aspects of alcohol consumption and its impact on the patient. So first is quantity and frequency. Questions 1 through 3 are going to measure how often and how much a person drinks. This is going to include frequency of drinking, typically quantities consumed, and then the frequency of heavy drinking episodes. So that's going to be defined as consuming 6 or more drinks on one occasion. All right, second are the dependent symptoms. So questions 4 to 6, and this is where we explore symptoms of alcohol dependence itself. So these includes impaired control over drinking, increased morning drinking, and the presence of withdrawal symptoms. Third are problems caused by alcohol. So questions 7 through 10 used to address those personal and social consequences. These include guilt after drinking, blackouts, alcohol-related injuries, and other concerns about one's personal drinking. So how do we score the audit? Each question in the audit is scored on a scale of 0 to 4, with the total scoring ranging from 0 to 40. So let's talk about it specifically. Questions 1 to 8. 0 is never, to 4, which is daily or almost daily. Questions 9 and 10, which address negative consequences, are scored from 0, no, to 4, yes, during the last year. Now, a score of 8 or more typically indicates hazardous or harmful alcohol use, as well as possible alcohol dependence, and this is going to warrant further diagnostic evaluation and interpretation by you, the PMHNP. Implementation and use of the audit. This can be self-administered or conducted by you, the healthcare provider, and it's going to make that versatile for use in multiple settings: primary care, emergency departments, mental health clinics, and it can be administered verbally or written as a questionnaire. So it's available in multiple languages, enhancing global applicability. Definitely something that you can utilize in many hospital, clinic, personal settings. Validation and effectiveness. So it's extensively researched, right? Like we talked about. Effectiveness has been identified across different populations. It's been demonstrated with high sensitivity and specificity for detecting those levels of severity in alcohol use disorder across all kinds of demographic groups. So made it the standard, really, for many national and international guidelines for alcohol screening. All right. So the purpose and benefits, primary purpose, like we stated, right? Audit is to screen for early signs of risky behavior. It's going to allow for that early intervention. It can range from simple advice or brief counseling to more comprehensive treatment for alcohol dependence. So early detection and intervention can significantly reduce the health, social, and economic burdens associated with alcohol misuse. So the audit is robust, evidence-based design. It's really going to help facilitate that detection. All right, let's move on to the second one, the CAG questionnaire. So this is going to be a real succinct screening tool. It's widely used for identifying those potential problems. Its primary aim is to detect alcoholism and heavy drinking. Unlike longer questionnaires like the audit, the CAGE is going to focus on lifetime alcohol use and behavior, making it particularly useful for quickly identifying long-term patterns of alcohol abuse. So we're going to use that acronym CAGE, and it's going to stand for each of the 4 key questions: cut down, annoyed, guilty, and eye-opener. So again, structure and content for the CAGE questionnaire. Number 1, cut down, or C. Have you ever felt you should cut down on your drinking? You're going to ask them these direct questions, yes or no. Number 2, annoyed. Have people annoyed you by criticizing your drinking? Number 3, guilty. Have you ever felt guilty about drinking? And lastly, 4, eye-opener. Have you ever had a drink first thing in the morning to steady your nerves or to get rid of a hangover? And we would consider that the eye-opener. So that's the E in CAGE. How do we score it? Each question is scored as a binary response: 0 for no, 1 for yes. So the total score can range from 0 to 4. A score of 2 or higher typically suggests a high likelihood of alcoholism, and it's usually used as that positive test marker, so indicating the need for further assessment or direct intervention. So the CAGE can be administered in a variety of settings, including primary care, psychiatric clinics, and non-medical environments. It can be used as a self-administered survey or conducted verbally by you, the provider, and the simplicity of the questionnaire allows it to be integrated easily into routine health assessments without significant time constraints, which, as you all know, a lot of times we only get 20 to 25 minutes for a 99214, 99215 coding. We have a little more time and potentially use something like the CAGE. But if it's a quick assessment, we can use something like this to really get a good idea of where they're at in their alcohol use and misuse. All right, so how is this validated? What's the effectiveness of the CAGE? So this questionnaire, again, validated across various populations, shown to be effective in lifetime alcohol-related problems. The brevity and straightforward nature of this screener, it does come with its limitations. So the CAGE tends to have a lower sensitivity in detecting less severe forms of alcohol misuse. Things like hazardous drinking or risky drinking behaviors, it doesn't really meet the criteria for dependence. So the key advantage of the CAGE is its ability to quickly screen for severe alcohol problems without delving into specifics of drinking behavior, such as quantity or frequency of alcohol use. It is particularly useful and effective in settings where time is limited and rapid assessment is necessary. Because it focuses on feelings related to drinking rather than the amount of alcohol consumed, it can be effective in identifying individuals who may not meet the typical profiles of heavy drinkers, but who experience that significant emotional or psychological consequences from their alcohol use. All right, moving on to the Michigan Alcohol Screening Test, or the MAST. It's one of the older alcohol screening tools designed to assess alcohol-related behaviors and problems. So it was developed in the early 1970s by Dr. Seltzer. The MAST is not only one of the first self-reporting screening tools aimed at identifying alcoholism, but it also remains widely used due to its thorough approach to understanding an individual's drinking history and the consequences of that drinking history. So it's been around for a while and for good reason. So the MAST consists of 25 questions that address a broad range of issues related to alcohol consumption, including medical, social, occupational, and legal problems associated with the drinking. So the questions are structured to reflect both the frequency of drinking behaviors and the severity of the implications of alcohol use. The questions are primarily yes-no format, making it straightforward, and the respondents can go quickly when needing to complete this specific screener. All right, let's talk about some of the sample questions that you'll hear. So, do you feel you are a normal drinker? So by normal, we mean, do you drink less than or as much as most other people? Have you ever awakened in the morning after some drinking and the night before found out that you could not remember a part of the evening that you were having? Does your wife or your parents or your other significant person ever worry or complain about your drinking? Can you stop drinking without a struggle after 1 or 2 drinks? Do you ever feel guilty about your drinking? Have you ever attended a meeting of Alcoholics Anonymous or AA? All right, so these are just some of them. There's 25 questions, so I won't go into all of them here. But you can see how this just dives a little deeper into the emotional response and can be a really good indicator of what that patient is thinking or feeling when they consider their alcoholic consumption. So the scoring for the MAST varies based on the potential impact of the question, with some questions weighing more heavily than others. So positive responses to more critical questions score higher, and the total score can range significantly. So this is going to reflect that severity of alcohol use and the related issues. Scores typically range from 0 to 53, with higher scores indicating more severe alcohol-related problems. Generally, a score of 5 or more is suggestive of alcoholism and is going to warrant further investigation by you. So the MAST can be administered in various settings, including clinical, workplaces, and in legal or counseling settings. It's useful for both self-administration and by you, the provider. So due to its comprehensive nature, the MAST is particularly effective in settings where a detailed assessment of alcohol use is more appropriate. The MAST has been widely used and validated and considered effective in identifying individuals with AUD, particularly those with long-term and severe problems. Its comprehensive approach is going to allow for that capture of a wide range of alcohol-related issues that shorter tests might miss. However, its length and the binary nature of its questions can sometimes limit its utility in quick screen environments where alcohol problems are less severe. So the primary benefit of the MAST is its depth and breadth in assessing alcohol-related issues. It's going to make it useful in determining whether or not you need to identify the presence of alcohol use disorders and the severity and the specific areas of an individual's life that are impacted by the alcohol. That's really that's really one of the best aspects of the MAST. So this can guide clinicians in tailoring interventions and treatments that are specific to the needs of the patient, because we dive into so many more questions than we would with like the CAGE or the Audit. All right, let's talk about treatments. So we've taken the patient, we've done an initial assessment, we've asked all these questions, we've used these screening tools, we've identified that treatment is necessary, or they're showing up with pretty, severe or potentially severe withdrawal symptoms. What do we do for it? So treatment options for alcoholism, which again is more commonly referred to now as alcohol use disorder, and alcohol withdrawal, they're going to vary, and it's going to encompass a wide range of medical, psychological, and supportive approaches. So these treatment options can be tailored based on the severity of the disorder, which can often be gauged using those screening tools that we just talked about. So you as the PMHNP are going to play a vital role in managing both the direct and supportive treatment regimens. So let's talk about these options and how they're linked to the screening levels that you just completed using the Audit, the CAGE, the MAST, and the CEWA that we're going to talk about here. So let's go ahead and move on to detoxification and withdrawal management. So the Clinical Institute Withdrawal Assessment for Alcohol, or CEWA, is a widely used tool for assessing the severity of alcohol withdrawal syndrome. It helps healthcare providers determine the appropriate treatment and help to monitor the progress of patients experiencing that alcohol withdrawal. So the CEWA scale includes various symptoms and signs that are commonly associated with alcohol withdrawal, each scored on a scale to quantify their severity. So let's talk about each of the components of the CEWA. Number one is going to be nausea and vomiting. How often the patient feels like vomiting or actually vomits. Tremors is number two. The presence and severity of tremors when the patient extends their arms and spreads out their fingers. Number three is proximal sweats. So this is the presence and severity of sweating just in general. Number four is anxiety, the patient's level of nervousness and anxiety. Now, I want to add a quick note here. None of these things can be pre-existing conditions, right? These have to be associated with the withdrawal. So if they have a history of, one of these things, we don't really take that into consideration. It really has to be involved with the withdrawal symptoms. Okay, number five, agitation. So the patient's level of restlessness or agitation is measured. Tactile disturbances. This is where you get the sensations of things like itching, pins and needles on the skin, burning sensations, or numbness. Auditory disturbances. The presence of sound sensitivities, auditory hallucinations, or other auditory disturbances. Number eight is visual disturbances. So this is the presence of visual sensitivities, such as hallucinations or other visual disturbances. Headaches, fullness in the head. It's often described as that fullness. The presence and severity of headaches or the sensations of the fullness in the head are all going to be measured. Number 10 is orientation and clouding of sensorium. So the patient's awareness of their surroundings, ability to think clearly, and orientation to time, place, and person. So each is scored from a 0, not present, to a 7, which is severe, except for the orientation and clouding of sensorium, which is scored from 0 to 4. So the total CEWA score helps guide the treatment decisions. 0 to 9, so when we add it all up, remember on that 0 to 7 or 0 to 4, if it adds up to 0 to 9, that's minimal withdrawal. 10 to 19 is going to be mild to moderate withdrawal. 20 and above, severe withdrawal. And this may indicate that there is more intensive treatment needed and more intensive monitoring, something like getting them in an inpatient setting or an acute detoxification center, obviously going to be needed in that severe of a situation. So for a total score of 8 or higher, so right at that minimal, top minimal cutoff line, we're going to start PRN treatments for withdrawal symptoms. For a score of 16 or higher, this is going to be scheduled medication ordered and also PRNs as that patient needs it. So you'll notice a different number starting point depending on which practice guidelines you look at. But generally, they're about the same, and it does vary greatly, but they're pretty much in the same ballpark. So for the purposes of your exam preparation and just in general, unless your unit tells you something different, we're going to use that 8 as a cutoff line, a starting line to start PRN, and 16 to 20 total CEWA scale to start PRN plus scheduled medications. So that's the CEWA as you start to roll into signs of withdrawal from alcoholism. So this is indicated. Let's talk about the indications. Severe AUD, indicated by high scores on screening scales using the Audit, scores greater than 20, the MAST scores greater than 25. The treatment approach that we're going to do based on that severity scale, medically supervised withdrawal, or what we call detoxification. This is in a hospital or specialized clinic setting. Medications like benzodiazepines, such as diazepam, lorazepam, they're commonly used to safely manage those withdrawal symptoms. We'll talk about that a little more here in just a few minutes. We really want to reduce the risk of seizures when we're helping the patient through the withdrawals. That's going to be vital. And then we just want to overall alleviate the discomfort that the patient is having. So what is your role as the PMHNP? Well, you may initiate and manage PRN as needed or scheduled medication treatments to manage those withdrawal symptoms. And then we're going to monitor the vital signs. We're going to give the orders to the nurses and the technicians to set those monitoring parameters. And then we're going to follow up and then treat based on what you find. We're going to look at those withdrawal symptoms. We're going to provide ongoing assessment and adjust treatment plans as necessary. So let's dive into the pharmacological treatment for alcohol withdrawal. First, we're going to talk about diazepam, also known as Valium. So this is a class known as a benzodiazepine. This is a long-lasting duration medication, which is why it's typically the go-to in these cases, diazepam. So diazepam is commonly used to manage alcohol withdrawal symptoms due to that long life that we just talked about. And this is going to provide a smoother withdrawal and reduce the risk of rebound symptoms. Now we also have lorazepam or Ativan. Again, this is a benzodiazepine class. Duration is intermediate acting, so we're a step down here as far as the duration goes from the long-acting Valium. So Ativan, lorazepam, it's preferred for patients with compromised or diseased livers because it is metabolized differently from other benzodiazepines. And this is going to make it safer in cases of liver impairment. So if you have a patient that presents with complications with the liver, then you're going to think about going with Ativan or lorazepam, that benzodiazepine that's intermediate acting, in order to treat your withdrawal symptoms. So it is effective in managing withdrawal and preventing complications like seizures. So the third medication we have is chlordiazepoxide or Librium. So again, benzodiazepine. Chlordiazepoxide is another long-acting benzo. It's used for alcohol withdrawal management. It helps to stabilize the patient and reduce the risk of those severe symptoms. So those are going to be your three go-to for pharmacological treatment of alcohol withdrawal. Primarily, we look at diazepam or Valium. Then we have lorazepam, Ativan, which is that intermediate acting, preferred for patients that have diseased livers. And then a third option could be the Librium. All right, so let's go ahead and move on to the next thing here, which is medication-assisted treatment. It's what we call MAT. You'll hear that in clinical practice. So this is indicated for moderate to severe AUD, typically starting at audit scores greater than 8 or a MAST scores greater than 5. So the treatment approach for MAT, these are medications such as naltrexone, acamprosat, or disulfiram. They're used to decrease alcohol cravings, maintain abstinence, or create an aversion to alcohol. Your role as the PMHNP is to prescribe these medications on a scheduled basis as part of a comprehensive treatment plan. So we have to monitor for adherence and then response to treatment and then make dose adjustments or medication changes as needed. All right, so going beyond medication-assisted treatment, we also use behavioral treatments. So these are indicated for all levels of AUD, useful from low to high screening scores. This includes cognitive behavioral therapy, CBT, motivational interviewing, and contingency management. Now, these therapies aim to modify drinking behavior through skill development, enhancement of motivation, and reinforcement of positive behaviors. Your role, obviously, is going to use these therapies to direct and then potentially refer patients to specialized therapists. Behavioral therapies are often scheduled regularly as part of the ongoing treatment plan. So you can do these therapies yourself, but a lot of times you'll be working with an interdisciplinary team of therapists and technicians and nurses to help administer and really manage these behavioral treatment options. Support groups and peer support is vital. So this is indicated for all levels of AUD as well. Beneficial regardless of the screening score of the patient. So participation in groups, support groups like Alcoholics Anonymous or other peer support groups are going to help provide emotional and social support to enhance recovery. Your role, encourage participation. Give them the opportunity and give them the knowledge and the flyers, whatever they need in order to help patients find suitable groups within their community. This is part of that broader supportive care approach that we offer as PMHNPs. That's what makes nurse practitioners different. We go that extra mile. Now, dual diagnosis treatment. This is when patients have co-occurring mental health disorders, which might be hinted at by high scores in any screening. So, we get high scores with the PHQ-9, the GAD-7, the MAST, the ALT, the CAGE. We really see this wide breadth of situations when there's a comorbidity. So integrated treatment is going to be key. Alcohol use disorder and co-occurring conditions like depression and anxiety. It may involve a combination of medications. So we've got antidepressants, which are going to need to be closely monitored if you have a patient that is also an alcoholic. We've got therapy between all of these different disease processes and disorders that we can mix together and try to come up with an appropriate treatment plan with therapy itself. And then we just have general holistic approaches. So it's vital for us as the PMHNP to diagnose and manage those co-occurring disorders. So we have to dive in a little deeper. We have to get really good assessments and family histories and past medical histories to identify what co-occurring conditions are actually out there. Is it a psychiatric condition and disorder with symptoms, or is it maybe a personality disorder with more characteristics? And so then we have to figure out what we're dealing with, and then how does that go into our treatment for alcohol as well. So all of those things are going to be your responsibility as the PMHNP. So treatment initiation is going to be based on those screening levels. We've kind of talked about that as we've gone through the different modalities. So low to moderate, that audit greater than 8, MAST greater than 5. Education, we're going to see brief interventions and possibly outpatient behavior treatments. PMHNPs may start with motivational enhancement therapies or brief counseling. And then when we jump into that moderate to high risk range, that audits of 8 to 19s, MASTs of 5 to 25, these are going to be more structured outpatient programs. So possibly MAT or medication assisted treatments, and frequent monitoring is going to have to be implemented when we start to get these levels in the assessment process, when we're going and we're actually asking these questions and trying to figure out where they're at. Where are they at in their drinking, and where are they at with potential withdrawal? All right, and then we get to the very high risk or severe. This is your audits greater than or equal to 20, the MAST greater than 25, likely going to need inpatient treatment and intensive management. This is where motivational interviewing comes into play as well. This is where you get to use your assessment tools to determine whether or not this individual is appropriate in the outpatient setting or needs to be admitted. This is going to include detox and long-term MAT. PMHNPs would be actively involved at this step in the full spectrum of care, from detoxification and then to the long-term maintenance and relapse prevention strategies that go into AUD. So each treatment and intervention level is critical and should be initiated based on the comprehensive assessment of the individual patient using those screening tools that we've talked about, and then the guides, the clinical practice guides that we have to quantify and qualify the need for different treatment modalities. All right, so we're really getting to the end of the presentation here, the podcast, and I want to just end on another note of medications, because I know we have a lot of questions about that on the exam prep as well as in clinical practice. So let's just kind of dive into it a little bit deeper for acamprosat, disulfiram, and naltrexone. Again, commonly used in the treatment of alcohol use. So we're not talking about withdrawal here. Those are going to be your benzodiazepines. Here we're looking at medications that treat alcohol use. They're going to have distinct mechanisms of use, and they're going to be associated with very specific clinical guidelines depending on the environment you're working in. So first one we're going to talk about is that acamprosate or Camprol. So the typical dose of acamprosat is 666 milligrams 3 times a day, or TID. It's usually started as soon as a person has stopped drinking. So it should be taken 3 times a day, again, with food or without food. So what are some clinical pearls? So acamprosat is thought to stabilize chemical signaling in the brain that would otherwise be disrupted by alcohol withdrawal. It's most effective for those who have already stopped drinking and are trying to maintain abstinence. It does not prevent the withdrawal symptoms that people might experience after they've stopped their drinking patterns, but it helps to reduce that urge to return back to drinking. You definitely want to check kidney function. It's got to be good in order to take this medication because it is excreted via the kidneys. Number 2, we have disulfiram or Antabuse. The typical starting dose is 500 milligrams daily for 1 to 2 weeks, followed by maintenance doses of 250 milligrams daily. So it should be taken in the morning, but if drowsiness is a problem with the patient, the dose can be taken at bedtime. So what are the clinical pearls for this one? Disulfiram works by inhibiting an enzyme involved in metabolizing alcohol intake. This is going to lead to unpleasant effects when alcohol is consumed, such as flushing, headaches, nausea, vomiting. It's nasty. So this is going to deter the patient or the individual from drinking. You must educate your patients. They should be warned about the possible severe reactions with alcohol and should avoid all alcoholic substances, including those that may not be immediately recognized as such. And this is going to be things like cough syrups, vinegars, sauces, certain soaps, or hand sanitizers. If it's got alcohol in it, it can be absorbed, and then it can really cause some nasty symptoms. It's important for patients to be fully compliant and motivated for therapy if you're going to start Antabuse, because it's going to require strict adherence. You do not give this to every patient. You got to make sure that they are on board and they understand the consequences of use. So patients should carry an identification card with them when they're on this medication, indicating that they are taking Antabuse and that they should avoid any alcoholic substances. All right, number 3 is naltrexone, Vivitrol. So dosing here, this is an oral form at 50 milligrams daily, once daily, or we do have an injectable. So there are 2 different medications. The oral is going to be Revia, that's the 50 milligrams once daily. The injectable is going to be Vivitrol, that's 380 milligrams intramuscularly every 4 weeks. All right. So you can see if a patient's compliant, non-compliant, the injectable may be a better situation for specific patients if that's available in your clinic. So the oral naltrexone is taken once daily. The injectable, again, that's administered once a month by you or somebody that's qualified within your organization. So naltrexone blocks opioid receptors that are involved in the rewarding effects of drinking and can really be a craving modifier to help stop those cravings for alcohol. So it can be taken by those who are still drinking when they start the medication. So maybe a little bit safer if you've got a patient that's maybe not telling you all the truth, or you just know there's a history here that could potentially, even though they're saying they're not drinking, they could be, and that antabuse might be super harmful for the initial symptoms that they may feel. So naltrexone might be a better option. So it reduces that pleasure. Now, liver function tests should be performed prior to the initiation of treatment. This is because we need to ensure there's no significant liver disease because of metabolization. So naltrexone may not be suitable for individuals who use or are dependent on opioid drugs, as it blocks the opioid receptors. So overall considerations, all these medications should be a part of a comprehensive treatment plan that includes psychological support and lifestyle modifications. It's crucial for you to discuss the potential side effects as well as the benefits of these medications when you're talking to your patients and their family members or whoever their support system is, so that way they have all of the facts going into the treatment. Monitoring and follow-up are going to be key components of successful treatment when using these meds, and this is going to make sure that they understand the adherence that they need to have and to address any emerging issues or side effects that may present. So this was a good overview of alcohol use disorder, some of the monitoring, the screening that can go into play, and then how we start treatments from the mild to the severe, depending on if we want to go just psychotherapy, just medication management, or a combination of the two. As always, there's a lot more information in the PMHNP certification review seminars. We look forward to seeing you online for the on-demand or at one of our live PMHNP conferences. We are AANP accredited for continuing education. We would love to be able to help you out with that, no matter if you're a student or somebody who is already in clinical practice for years and years. I'm Dr. John Rossi for Clarity Education Systems and www.PMHNPtesting.com. I will see you in the next podcast and in the seminars. Thanks so much for listening. Bye-bye.